Hello, everyone, and welcome to today's NDARC's weekly webinar. My name is Tom Santo Jr., and I'm a postdoc at the National Drug and Alcohol Research Center at UNSW Sydney. I'm delighted to again be your host for today's session, engaging with OAT, or opioid agonist treatment in New South Wales, and a mixed methods study of treatment access and retention. Before we begin, I would like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land from which I'm presenting today and on which NDARC is located. I'd also like to acknowledge the traditional owners of the country throughout Australia and recognize that our speaker, panel members, and audience may be joining from different Aboriginal lands. We pay our respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people here with us today. So today's webinar is going to be taking a closer look at OAT engagement across New South Wales. OAT is one of the most effective, or is the most effective evidence-based treatment we have for treatment of opioid dependence. Yet we know that in New South Wales, across Australia, and globally, that many people face barriers in getting to treatment, accessing it, and then staying engaged with care. And so today we'll hear about data and lived experience perspectives that shine a light on access, service experiences, and engagement, and what supports longer-term retention. It's today my great pleasure to introduce today's presenter, who will be presenting via a recording just to prevent any technical difficulties. That's Maud Groothuizen, and apologies for my pronunciation if that was off, but Maud was a global health master's student at Vrije University in Amsterdam and has a Bachelor of Science in Sociology and strong research focus on mental health addiction care. Maud had spent a couple of months, about 4 or 5 months, at NDARC while completing her master's thesis on the barriers and facilitators to engagement with OAT in New South Wales. And today we'll hear findings from her main thesis project. I'm also excited today that we'll have Rob Page joining us as a panelist. Rob's an addiction medicine specialist with a background in general practice, who has a strong interest in treatment of people with opioid dependence, with substance use disorder, and background in harm reduction. We also did have Mary Harad, and would like to thank her for joining us in the previous um, iteration of Maud's presentation. Unfortunately, she wasn't able to make it today, but would again like to thank her for her support throughout the opioid dependence survey and for joining us on the previous iteration of the presentation. So today now we'll go to Maud's pre-recorded presentation, and then afterwards we'll have the Q&A with Rob Page and with Maud, and we'll have your Q&As posted throughout the chat, and then we'll get to them throughout the Q&A. So thank you so much, and we'll now go to Maud's presentation.
Hello, everybody. Good morning or good afternoon, depending on where you're tuning into. I'm incredibly excited to be speaking with you today about a project that I conducted as part of my master thesis project, for which I spent 4 months in Sydney, Australia. I conducted a project on engaging with opioid agonist treatment in New South Wales under the supervision of Dr. Simon Clay, Dr. Michaela Kowalski, and Dr. Kriana Barat. I personally have a background in sociology, and I did my master's degree in global health, hence why I spent 4 months in Sydney, Australia. So yeah, let's get started. According to the Australian Institute of Health and Welfare, in Australia, approximately half of the drug-induced deaths are attributed to opioids. And for me, this is just one of the many statistics that underline the need for clear and accessible entry points to treatment for those who are suffering from opioid use disorder. And as most of you will be familiar with, opioid agonist treatment, also known as OAT, is the most effective and most well-known form of treatment for this specific clientele group. Opioid agonist treatment is a long-term medication-based treatment which is known to reduce all-cause and drug-related mortality, lowers the risk of bloodborne infections such as HIV and hepatitis C, lowers criminality, and improves overall health, meaning both psychosocial as well as physical. But unfortunately, despite these proven benefits, retention rates into OAT are lower than we would want them to be. It's actually the case that the longer you're enrolled in treatment, the more benefits you're likely to get from them. But unfortunately, the work of O'Connor et al. In 2020 has shown that globally retention rates drop to below 60% a year after treatment initiation and to below 40% 3 years after treatment initiation. So this really underlines the missed opportunity here for retaining these people into this form of care for years or even decades, depending on what that person needs, of course. Within the context of New South Wales and Australia, we are aware of some specific barriers that are present, such as, for example, the lack of prescribers. In Australia, it's currently the case that general practitioners only have a very limited capacity to take on clients for opioid agonist treatment. They actually need to follow additional schooling to become accredited to take on a larger clientele group. But this is on a voluntary basis, and unfortunately, many general practitioners choose not to engage with this form of additional schooling. This has led to a situation where, according to Jones et al. In 2017, more than 80% of this clientele group is served by only 20% of the available prescribers, of course, causing a huge strain on this part of the health sector and also leading to very tangible outcomes such as prolonged waiting times and just an overall lack of accessibility from actually making it into care. On the other hand, there are also requirements employed throughout treatment, such as urine drug screening, supervised dosing, and restricted take-home doses, which are actually put in place to promote patient safety and that of the clinicians, as they work as a tool to basically monitor whether an individual is actually taking their medication, whether they're not diverting it to other people, but also whether they're not using any other substances simultaneously. But unfortunately, when you apply these requirements or these measures in a negative way, they can actually work counterproductive and foster a negative treatment environment, which is known by the work of Fitzgerald et al. In 2025 to actually decrease retention rates and therefore miss the point of what it's actually set out to do. Despite these barriers being known, there's still a lot that we do not know about the current situation. So our study set out to explore opioid agonist treatment engagement to deepen understanding of the systemic and interpersonal dynamics influencing this engagement in specifically New South Wales, Australia. And on the right side of this slide, you can see on the top the main research question and then the two sub-questions, which are distinguishing between accessing and retaining. And those are the two components that we use that make up the engagement with OAT. As you could probably see on my first slide, we employed a mixed method study. So I quickly want to talk about the quantitative component that we used as a data source, namely the opioid dependence survey. The opioid dependence survey was a large-scale survey enrolled in New South Wales in 2023 among people with opioid use disorder. It was an incredibly rich data source to work with, and I'm truly so happy that I got to use this as my quantitative tool. It covered so many different things. It was sometimes a bit overwhelming. Topics included were social demographics, mental and physical health, substance use history, overdose history, incarceration, arrest, treatment history, treatment preferences. Truly, the list goes on. But yeah, of course, we looked specifically at the data points that were relevant for the story that we wanted to share. And today, I'll be sharing a summary of all the findings that we had in the final report. This is an overview of the total methodology with on the left side of this table, the quantitative component where you can see the opioid dependence survey and the more than 400 individuals that participated in this. And on the right side, you can see the qualitative component, which comprised of semi-structured interviews with peer workers. And peer workers were actually a very interesting participant group to speak with because of their unique setting in the community where they have a more so bird's eye view of what goes on, since they engage with multiple clients, with clinicians, sometimes even with government officials, and potentially also come from a lived experience background. And because of this special position, they were very relevant and interesting data points to have this conversation with. This is some detail about how we actually went about distinguishing the two data sets. where you can see on the left side here, the quantitative survey was distinguished based on treatment history. So you can see that we made a distinction between those currently receiving OAT, previously receiving OAT, and never receiving OAT. And we did this to basically compare data points and see where the stories were differing, what we could potentially derive from that, to foster a better understanding of the different trajectories with care that people walk. On the other hand, you see the qualitative interviews, where we conducted 13 in total, of which the majority was female from a metropolitan area and worked in a harm reduction service. We also spoke with people that work in a clinically led service, and this is, let's say, a hospital setting. And we actually made this distinction because there was a data point that these two work settings seem to differ on. And I'll also discuss it in the results later on and point it out when we get there. Just as an overview for how we actually went about conducting the project, since we of course employed a sequential explanatory design, we started with the quantitative component, but we actually chose to really start everything with these two questions of the opioid dependence survey specifically, namely, what is the primary reason you have never received medication, and what is the primary reason you are currently not receiving treatment? And you can probably immediately understand why these two questions are so relevant for what we were trying to look into in this project. So because they were open-ended, we actually had to employ a qualitative content analysis, so a qualitative research method, to understand what the answers were telling us here. And this then functions as sort of the backbone for the rest of the project to extend on, basically. And you can see that we follow it up with the rest of the quantitative survey analysis, and then also lastly with the qualitative interviews. Quickly circling back to this first point with the two open-ended questions, you can probably understand or already grasp that with the way that they were formatted, that they were very likely to elicit a very broad range of answers. And this was also very much the case. It was incredibly interesting to see what the answers were telling us, but also very difficult to analyze them properly because they were so scrambled. So we quickly came to the conclusion that we needed some sort of tool to help us structure the analysis for this part. And we chose to do that with the theoretical framework of Eiraldi, which you can see here on this slide, Eiraldi's help-seeking behavior model. And it's a very straightforward model where you can see an individual with a medical problem, recognizing that they have this problem in the first place, and then moving through all the stages to eventually utilizing a service for it. So this helped us understand where these answers were coming from, to help them place on this continuum, and then also understand whether the answers that were given actually even pertained to the service at all, or were more so in a more personal dynamic in relation to the need for care. But we also found that despite this being an excellent starting point for actually understanding what these answers were telling us, there were some that didn't quite fit into this model one-to-one. So we chose to adapt it to where you can see it now here. In this specific version, we defined the problem as opioid use disorder specifically, and also service as opioid agonist treatment. And we added the two yellow bubbles, and I'll quickly walk you through what they mean exactly. They're pretty straightforward, probably also based on the name already, but the first stage, the pre-awareness phase, as the name implies, it's basically a phase where people meet the clinical requirements for having opioid use disorder, but they do not so recognize having this problem themselves. So therefore, they're not yet at a point where they recognize that they have a problem, but in an earlier phase. On the other hand, we also have the service access stage. This is because in the first model, service selection naturally led to service utilization. But we found there were a lot of answers that were actually falling somewhere in between the two. And therefore, we wanted to devote a stage specifically to that to better understand the continuum that's applied to opioid agonist treatment engagement. It's important to note that despite this model being a linear representation, of course, day-to-day lives are much more complex than this, and it's a simplified version of reality, and people jump through the model multiple bubbles at once, or they fall back once they've reached the end. So it's not as simple, unfortunately, as it is depicted here. And it's also important to note that this model shouldn't be applied to everybody across the board, but it's only applicable for those that eventually want to seek help. You will see this model come up for the rest of the presentation because we actually chose to use it throughout the rest of the project. And we actually ended up using it as the format to structure all the findings based to the specific stages. So let's get started. For stage 0, the pre-awareness stage, you can see here on this table on the left that we compare those currently in OAT with those never in OAT. And those never in OAT were less likely to have ever injected drugs and more likely to have smoked their first illicit opioid. This last data point is in contrast to injecting your first illicit opioid. We also found that those never in OAT were significantly later in age or older in age to start using their first illicit substance in contrast to those currently in OAT, namely 16 years old versus 14 years old. And we figured that these data points were sort of telling us a story where those never in OAT potentially walk a less severe drug use trajectory, and how this may contribute to them maybe not even recognizing that they have a problem to start with, and therefore, of course, not consider help, because if you don't have a problem, you don't need help for anything. And they might also delineate themselves from other opioid users that have a more severe drug use. On the other hand, we also found that those currently in OAT were way less or significantly less likely to be using oxycodone and codeine compared to those never in OAT. And this also goes for past month use of morphine and tramadol, where you can see that those never in OAT had much higher rates than those currently in OAT. And this is also aligning with the literature that's available, where you can see that pharmaceutical opioid users are actually likely to engage in some sort of othering process, where they, again, delineate themselves from other opioid user. They already distinguish their problem as essentially very different, and therefore, of course, don't consider the same form of care. This was also recognized in the interviews, where you can see this quote. And again, there's that stigma. You know, I don't want to end up on methadone. I had a car crash and busted my back in 3 places. I don't want to hang out with OAT recipients. And again, this is a really good narrative that underlines the othering process that takes place, the delineation that takes place, and how pharmaceutical opioid users don't consider their problem as the same and therefore do not consider the same treatment. And altogether, these findings of this stage really illustrate that the pre-awareness stage is characterized by a combination of a lower perceived need for treatment, potentially less severe patterns of opioid use, the influence of stigma, and then particularly around the identity of an OAT client. And altogether, individuals may remain outside of the formal care system, and this is then not due to a lack of access, but rather due to a fundamental disconnect between lived experiences and dominant perceptions of treatment models. Going forward to stage 1, the problem recognition, I first want to direct your attention to this graph or the table on the right, where you can see that those never in OAT were much more likely to suffer from houselessness and to not have access to Medicare or concession cards. And for us, this really told a story that people may be fully aware that they have a problem going on and they might even want to receive help for it. But when they have more immediate, more pressing issues at hand, such as houselessness or a reduced capacity to actually engage with care, then we cannot expect them to just make it into treatment and wonder why they're not doing that already. On the other hand, you can see that those previously in OAT and never in OAT, significantly higher rates to be using methamphetamine. And it's of course important to keep in mind that for the quantitative data points, all the participants had opioid use disorder. So we knew that they were engaging with opioid use as well. So these high rates of methamphetamine use then imply that there is polydrug use going on. And this was also recognized in the interviews, where you can see this quote: "We will get referrals and the primary drug of concern will be one thing, but then obviously the conversation I might have during intake, the client will be like, I'm not concerned about my meth use. My meth use is fine. I'm quite happy with the meth that I'm using. I probably smoke too much weed. Let's address that. Thank you very much. In this instance, this participant was talking about meth and weed, but you could, of course, interchange those with opioids and any other type of substance. And it really underlines how it's not just a simple equation where, oh, someone has opioid use disorder, so they should engage in opioid agonist treatment. If there's another addiction going on that is impacting their day-to-day much more severely, they might not benefit from a treatment that is not tailored to that specific type of addiction then. So overall, this stage really reflects a complex interplay between individual readiness, structural barriers, and shifting treatment priorities. While participants can acknowledge that their drug use is problematic, factors such as housing instability, limited healthcare access, competing life demands, and a mismatch between available treatment options and the primary concern, such as methamphetamine use, can really impede someone's progression towards help seeking. And this stage therefore really underscores that recognition is just simply not enough at times if you don't have the right supportive conditions to actually act on that awareness. For stage 2, we actually had a question on whether your doctor discussed the following points: treatment options, medication available, and medication choice. And we compare here those currently in OAT and previously in OAT. And you can see for that last point with medication choice that the difference between the two groups is rather big. And this was also something that came up in the interviews quite a lot, where you can see, for example, this quote, well, the doctors are pushing Buvidal. They've told me specifically, like when I go to work, you need to start telling more people about Buvidal and trying to get them to switch. So I know they're actively trying to do that. To which I asked, do you know why they're trying to do that? And they mentioned, just because it's less traffic, less people coming in, and they don't need more staff, so they can deal with more people. And then if more people are on the injection, then they can bring more people into the treatment program. And of course, when you look at this quote like this, it only makes sense that this is the narrative. If you can see, if you can serve more clients with less staff, what is there not to want about this, basically? But then we were also speaking with other participants that, for example, shared a bit more about medications such as methadone. And one of them told us the following. But then again, some people thrive on the daily dosing. They thrive on the turning up at the clinic, that sort of regimentation that I've got to be here at a certain time. And it also enables them to catch up with their friends and so forth. It might be their only outlet, turning up at the clinic. And you really see here the differences in how you approach such a topic where reduced contact moments at first face value seem very desirable and seem something that would be beneficial for everybody. But if individuals don't have any other obligations going on, such as family or work or whatever it may be, and how this quote explains the clinic is the only thing that they get to do every single day and their only social contact moment, taking that away from somebody is actually very counterproductive and can really negatively impact the treatment experience and therefore not contribute to improving the retention rates. So you can see that for this stage specifically, the service selection is a very deliberate process that should be tailored to an individual's living circumstances, obligations that they may or may not have going on, their values, and also what they want to get out of treatment to make sure that this is all optimized to the situation of this individual specifically. For stage 3, the service access stage, we actually didn't have any quantitative data points that were relevant to share today. But we did have some other interesting quotes from the interviews. And this first quote actually aligns with what I mentioned in the introduction about the lack of prescribers. And this participant was sharing how they understand the situation, namely to be as followed, where they explained, but this is the thing, right? The doctor can write a methadone script on a bulk billed appointment, or they can take skin cancer of someone in 20 minutes and get $600 from Medicare. What's the doctor gonna do? Is he gonna train to become a certified OAT prescriber? And also, there's a chance that people won't turn up for appointments, that they will be rude in the waiting room, or might be inebriated. And again, this is sort of the same with the previous quotes, where it makes a sense when you look at it like this, that there is little to no incentive for a prescriber to take on additional schooling, to serve a more chaotic clientele group, which also carries no financial benefits. So while that makes sense, it is unfortunately the case that the fact that people are refraining from taking on this additional schooling and serving this clientele group leads to very tangible barriers, such as prolonged waiting times, such as difficulty for people to find available prescribers, and overall just contribute to a more negative and less inviting, less easily environment to navigate. We also have this other quote for this stage where this participant was sharing, "The majority don't know that the services are available. It's like everything's behind an iron curtain." And while this quote is rather short and you might brush over it within this presentation, I do want to take a moment to really devote attention to it, because for me, this is one of the most interesting findings that we got, where both clients are sometimes very unaware of what it actually looks like to engage with opioid agonist treatment, what the process to get into this form of treatment actually looks like. And there was a lot of scenarios where participants described misunderstanding, where people will potentially go into withdrawals because they think this makes them more eligible for treatment, but then working counterproductive because they don't have any substances in their system and therefore making them ineligible for engaging with care. But also, peer workers struggle a lot with effectively navigating new people onto available treatment services, because they're often unaware which facilities have availability opening up, what services they provide, what requirements they employ, because this is also something that came up a lot, where requirements for entering into treatment seem to differ a lot depending on where you were going. So some facilities may have rules regarding polydrug use or mental health issues, and all this variation just fostered a lot of confusion, also because there's no central point of oversight where you can just call something and you know who has availability opening up where. And this often led to a situation where if someone new presents to a harm reduction facility, the peer workers can't really offer them anything there and then, and need to ask if they can come back in a couple days. But a lot of people are lost for engaging with treatment because of this, because they go back to their living circumstances, how it was before, and when they finally mustered up the motivation to commit to treatment, you want to grab them there and then and offer them something. And if they leave empty-handed, then this is of course the complete opposite of what they presented to the clinic for at first. So together, these findings really paint a picture of a system that, despite individuals' readiness to engage with it, can place very significant interpersonal and structural barriers in their path. And without clearer entry points, greater service information, and an increase in available prescribers, many people can potentially remain stuck at the threshold of treatment initiation. Going to this last stage already, on the left you can see a table which just has some overview of information regarding the medications that are available in New South Wales currently. And on the right side you can see a table that represents the question on treatment satisfaction per medication type. And what probably stands out the most is that methadone is rated the lowest out of all. And I do want to address that methadone is also the medication for this question that has the highest standard deviation. And this then talks about the range of answers basically that were given to answer this question. So some people really didn't like it and some people really did. And this ties back, of course, to the quotes from the surface selection stage, where there's just so much variation in what people actually want to get out of treatment, what they need from it, that I think we should look at this table as all the medications are given a sufficient grade, generally are rated pretty high. And this is something to be really proud of. And the fact that we have 5 medications that are available is something that's very powerful and something that should be continued to be the situation, because it just provides more tools to actually tailor treatment to the individual specifically. For the interviews, this is actually the data point where we contrasted or compared harm reduction participants and clinically led service participants. And they were actually discussing the requirements that are imposed throughout treatment, specifically the urine drug screening. And you can see this first quote where this participant from the harm reduction service was explaining them as follows. Urine tests can be a bugbear. A lot of doctors use them in a punitive way. If you've given a positive test for drugs in your urine, a lot of doctors will straight away remove your takeaway doses if you have any. And this is very much opposed by this other narrative, where this other participant from a hospital-based setting was explaining that when someone presents at their facility with a positive urine drug screening, they go about like, we noticed that this other drug is in your system. That's your business. Are you interested in getting any support around cannabis or crystal meth or anything? If the answer is no, that's okay. And if you do want support, just come and ask. And of course, this latter approach is the one you would want to see standard across the board, because in this instance, it's actually used as a tool to tailor treatment to the individual. But when this is not the case and it's applied as the first quote, like I mentioned in the introduction, this can work very counterproductive, and literature has shown how this can actually have a deterring effect and make people walk away from treatment altogether. And in the worst instances, it can foster a very stigmatizing environment. And this leads to the last quote of the results section, where this participant was sharing, stigma just puts up barriers, and if people don't get treated well in drug and alcohol treatment spaces and are treated like drug addicts, they don't think they're going to get treated well elsewhere. And unfortunately, this is something that I think came up in every single interview, where negative experiences in alcohol and other drug treatment spaces really foster a scenario where people just choose to disengage with care altogether. And many participants that I got to speak with actually knew of people that chose to walk around with medical issues for sometimes even years, for which they could get medical care very easily, but they just refused to go back to a medical service that made them feel so bad in the last attempt, that they would prefer walking around with the discomfort of whatever medical issue that they have going on, rather than getting treated for it. So I think we can all recognize that this is, of course, the complete opposite of what the medical system is here for, and therefore it's so important that we address the right resources to improve the situation to benefit the scenarios of or the living circumstances of these individuals. And together, these findings of this stage really illustrate that successful service utilization doesn't just depend on medication efficacy, but also on the quality of interpersonal care, flexibility in service design, and attention to clients' broader social needs. And if this is not done correctly, clients may disengage even after moving all the way to the help-seeking behavior model to the end, after initiating treatment. And yeah, this is, of course, the last thing that we would want. So what did we learn? The barriers for accessing opioid agonist treatment. Of course, in the pre-awareness phase, we learned that there's potentially less severe opioid use going on among those that don't have any history engaging with opioid agonist treatment. Pharmaceutical opioids can also contribute to this othering process that seems to take place, and where people don't consider opioid agonist treatment as a form of care that they could benefit from. In the next stage, we learned that polydrug use may potentially skew the attention to other forms of addiction going on, making opioid agonist treatment not the most suitable form of care for those individuals, but also how houselessness and lack of accessible healthcare due to a lack of Medicare and concession cards can play a role. The longer waiting times, of course, partially due to the lack of prescribers, the lack of information, where both clients as well as peer workers really experience the system as opaque and difficult to navigate, and how this can really impede the ease of entering into care. The lack of patient autonomy, medication choice. This is actually, this shared decision-making regarding medication is a crucial component for patient-centered care, which is particularly relevant for people suffering from chronic illnesses such as opioid use disorder. So continuously safeguarding that patient autonomy with medication choice can really greatly contribute to improving access and treatment experiences. Barriers for retaining people in care. We see, of course, the measures being applied punitively and how this can even result in a stigmatizing environment, and how you, if you switch that around, can completely reverse the situation. For limitations, no work comes without it, so also not mine. The opioid dependence survey had a cross-sectional design, so I couldn't make any causal inferences within the data. The quality of the open-ended questions was also rather low because the opioid dependence survey was administered with an interviewer and an interviewee. And then the interviewer summarized the answers that were provided. So we actually try to combat this by verifying them in the interviews to get some additional nuance and better understand what these stories were trying to tell us. Of course, be cautious with generalizing these findings outside of New South Wales because both the survey as well as the interviews have only been conducted within this specific context. Some policy recommendations. We argue that clarifying eligibility criteria to access treatment and available options can, particularly among those who are peer workers and others in service navigation rules, can be vital to improve access. Strengthening patient autonomy within treatments can improve retention. So this is, of course, related to the provision of medication choice and including the patient in the shared decision-making process. We also argue that additional supports for healthcare workers in alcohol and other drug treatment spaces, such as clearer guidelines for the requirements imposed throughout treatment to stimulate a more pragmatic approach rather than a punitive one. Plus, providing supports for those experiencing socioeconomic hardship can both really contribute to bolstering treatment access. And yeah, that's all for me today. I quickly want to take this opportunity to thank you all for being here, for listening to my story, and I'm very curious to learn what kind of questions you may have for me. I also want to thank my supervisors, Simon, Michaela, and Kriana. Thank you a million times for your wonderful guidance throughout this master thesis project and for welcoming me so nicely for those 4 months I spent in Sydney. I learned more than I hoped I would, and I'm eternally grateful for that. This is, of course, also extended to the other people working at NDARC who make my time there so enjoyable. And also definitely for all the participants that participated in the opioid dependence survey, but also the peer workers that I got to speak with. I'm eternally grateful for the stories that you were sharing with me and your openness. And yeah, I hope this project can somewhat contribute to bettering the situation. And yeah, thank you all.
Sorry, Tom, I can't hear you, mate. I'm not sure if others can.
Okay, how about now?
Yeah.
Awesome. Sorry about that. Almost another technical difficulties, but thank you, Matt, for your presentation online, and thank you, Rob, for joining us again. Wondering, Rob, if you wanted to start off maybe with just some overall reflections from the presentation, and just get your initial thoughts from what Matt presented on.
Yeah, of course. Thanks a lot, Tommy. I'm here in Gadigal land in Sydney, and I appreciate you having me along today. Thanks so much, Matt. That's fascinating. I appreciate you inviting me. Now, I'm talking as a clinician, right? Not someone with lived experience. I'm sorry that I can't provide a perspective from that side of things. But yeah, look, looks like it was a big old data set, and wonderful for you to have been able to extract these really interesting things from it. I mean, as someone who works every day in an opioid treatment service, it's really good for me to be presented and sometimes confronted with these things about the difficulties people have in even getting through the door to come and talk with us and then maintaining engagement with us, especially those stories where people don't manage to or have a really negative time of it. And so we need to reflect on the issues with both with the systems, but also with us as individuals in terms of what we do and what we say that mean people don't feel comfortable or feel stigmatized. I mean, as I understand it, we've got sort of 50 something thousand people in Australia on OAT on an average day and 20 something thousand in New South Wales, but it means the burden of disease is probably much bigger out there when it comes to opioid dependence because there's always such big demands on services for treatment. I've worked in general practice as well as in drug and alcohol treatment services, so I guess I have a bit of a feel for how difficult it is. And I appreciate the reflections of that one. I think it was like peer number 4 or something saying, yeah, it's poorly paid. People don't show up for their appointments. I never found really that people were like abusive or anything like that. It's just like people have hard lives and it's difficult for them to come. But if they don't, then GPs don't get paid. So it's sort of tough on both ends, but definitely tougher for the clients, I think. So I thought those reflections were really interesting. I mean, other thoughts like you didn't go into it, and I imagine it probably came out somewhere there. Just the challenges in Australia at large, but also in New South Wales, geographic, people in rural and remote areas trying to get to see a doctor who knows about opioid dependence, find out where to go to a service, see if there's somewhere that's telehealth. And I thought your suggestion of like a centralized number or service to say, hey, like, where can I go? Is there space for me? Am I going to call this number and not get a call back? Like that's a really good and practical suggestion. And otherwise, yeah, look, I've got so many notes, but I want to open the floor to everyone else as well. But I thought, yeah, urine drug screens, it's something that sort of comes up all the time, and it's so rough that that's the experience people so often reflect on because the guidelines are really clear, right? Like, I mean, yeah, they can be a useful part of it, and I think they sort of say they're a like a vital part of the opioid treatment program, but they also say really clearly the benefits and the pros and cons of them should always be considered, especially with false positives, false negatives, and the ability to disrupt the doctor-patient relationship. And we should always be thinking about that, not to say that we shouldn't do them, but to say that we should like cautious, judicious about the use of them and really communicate well about why we're doing them, not making people feel like they're just gonna get in trouble if something comes up. But look, I'll hand over to you, man. No real questions there at the moment, but just a few reflections to get things started.
Yeah, no, but definitely regarding the last point that you offered, like there was also some understanding within the population of why these measures were applied at all. Because of course, yes, they provide a tool to monitor their safety and whether they're using any other substances. And like I mentioned in the presentation as well, it could actually be a very useful tool to improve the quality of care because you can actually adapt it to the individual more specifically. But it was also a very sensitive tool in terms of when you apply it in the wrong manner, it can also just really be counterproductive. So yeah, maybe I agree with you that the guidelines are relatively detailed on it, but there should be some brainstorming about how it can be communicated, maybe even more thoroughly of what it actually looks like, what the impact can do. And yeah, it's just so difficult with how many variations in circumstances and individuals and whatever can be on how to effectively apply it. Yeah.
Agreed. Yeah, I mean, I know the guidelines are currently being revised, the New
Yeah.
South Wales ones at least, and so I'm not sure if work will be done on that space of things. But as you say, hopefully it sort of is made clearer again about how to
Hmm.
use it and use it well.
One thing I just wanted to note, to I guess shout out, and maybe something that we need to give more information on to people who are seeking opioid dependence treatment is that there is an opioid treatment line, I believe. So just wanted to note that in terms of maybe just how we potentially get that out to more people that are seeking treatment, and I'm not sure if they cover some of the stuff that you were suggesting, Maud, and Rob, if you know anything about, yeah.
Yeah, look, I do know it's great, right? And that was one of the notes I made too. Look, the OTL, it's fantastic. I just did a quick Google, like how to access methadone in New South Wales, and I think it was like the very bottom link on the first
Yeah.
page. Like, and obviously my algorithm probably shapes what I find, but I guess it can be a bit tricky to know that that's where to call. I think the newer access lines that are run and serviced by peers and people with lived experience is fantastic because they'll both point you in that direction, but also potentially help you to like confront or deal with stigma or difficulties in accessing services can be a useful one too. I know that the opioid treatment line will generally help to point you in the direction of your local service, but I'm also aware from talking with people who've tried to come to services that it can then be tricky. Sometimes you'll phone the number of your local service and you'll get straight through to someone and they'll help you. And sometimes you might phone the number and you leave a message and then you might get a call back 2 or 3 days later. But if you don't have a phone, then I mean, how do you even phone the number in the first place, right? So it's that's sort of like depending on the privilege of having some things that some people don't have. So, but yeah, OTL and the newer helpline are both really good. Yeah.
Yeah, I wasn't aware of that being available, but I think that also illuminates for me speaking with so many different people, of course, that they might also not be aware from it. And then also, of course, the side of the peer workers, I found that pretty staggering where the fact that they also don't have an oversight and also are fairly limited in what they can actually offer an individual in that moment. So there's definitely some room for improvement there, but yeah, all the better.
No, I just wanted to, while we wait for some more questions to pop up in the chat, if you wanted to, I'm wondering to know if you had anything surprising that you found, or what was most surprising in terms of what you expected coming into the interviews and then going out. Yeah.
Yeah, thank you for asking. Um, I think what stood out most to me is what we just quickly talked about, the opaqueness of the system, where for me, reading to the guidelines, it seems relatively clear cut, but then how the guidelines, for example, are applied in real life in terms of requirements for eligibility, the variation that seemed to emerge was something that stood out to me. And yeah, the confusion that it also, of course, leads to. What else stood out to me? Yeah, I think as well, just some people had a lovely time entering into care and getting appointed the right doctor and building a good relationship with them and just overall getting all the benefits that opioid agonist treatment can provide from it, which was wonderful to hear about. But then all the peer workers that I got to speak with also knew of individuals that had complete opposite experiences and how specifically the client-doctor relationship can really make or break the whole treatment experience. So yeah, just the whole range of answers that were basically provided and how some people really recognized the confusion and others didn't really do so much. Yeah, it was interesting to see that it wasn't just one clear-cut experience on how to enter into care and how to be retained into it.
Very interesting, yeah. Rob, there's a question that just popped up in regards to how, if you had any thoughts around increasing uptake of prescribing amongst GPs.
Thanks, Tom. Yeah, sorry, I only laughed just because when I started doing the OTAC, the opioid treatment accreditation course, that's the one that, as Mal mentioned, you do further training, then you can treat more patients. Now, all GPs, even without further accreditation, can take on a certain cohort of stable methadone patients or initiate and prescribe for buprenorphine patients. And when I started doing it back in 2014 or so, I was involved in a couple of panels about, oh yeah, how can we increase prescribing amongst GPs? And I had old hands there laughing and rolling their eyes. Oh, we went through this 10 years ago, and the ones that did it then were reflecting on how it happened before that. I feel like look, I shouldn't be so cynical. It has been an issue for a long time. We're lucky in New South Wales that we have reasonably well-funded public OTP services. I think the government does very well investing in that versus I think in Victoria and in other jurisdictions where most of the services are provided by GPs or by private clinics. And so if we're looking to have GPs involved, we need to make it easier for GPs to be, I think, to be compensated appropriately for their time, to be supported in the work that they do. It's very isolating if you're working as one or like of the few GPs or the only GP in a practice or in a town providing opioid treatment, because if you go on holidays, then you rely on someone else to take on your patients. But what if no one else is interested? You sort of feel tied to your cohort of patients, and you really do want to ensure that they're getting the best care, but we've also got to take care of ourselves as well, right? So it's tough, but I would say, yeah, ensuring adequate compensation for the time that GPs are taking to work with clients with often really complex needs, providing support. And I know that DASAS, the New South Wales Health, provides this excellent line, Drug and Alcohol Specialist Advisory Service, where many GPs don't know about it, but it's just for health practitioners, doctors, allied health professionals, other people, health workers can phone that 24/7 and speak with an addiction specialist about these things. So letting GPs know that if they confront complex issues, they will be supported through those, and it won't just be left for them to deal with all of the challenges that can come up. And I think as well, like exploring other options, that I'm aware that New South Wales Health is also funding positions for GPs to go in and do a day or two a week in addiction medicine services to learn the ropes, to establish what it's like to practice well in this space, to learn more about the systems, and then hopefully carry that with them back into GP land. That's how I started doing it, working in public homeless health clinics, doing OTP stuff, and then carried that with me into GP land and Aboriginal health. And I loved it, and I still enjoy it. But I also see why people don't do it. I know there's ongoing work to try and improve that, but I guess, yeah, that's a few thoughts from me. I'd love to hear if Maud has any thoughts as well.
Yeah, this is a part of the work where I didn't go in too deeply about, because of course, speaking with the peer workers, I could only really understand the situation from their perspective specifically. So I do want to highlight, of course, coming from that part of knowledge. But it's good to know that there are tools available already, such as that helpline, which really makes me think. Same goes with the opioid treatment line. There are already a lot of assets available in the field, but just disseminating more knowledge about it, maybe easing the newness or the scaredness that you can get from engaging with care, or as a prescriber to engage in such a new field of prescription, can really already just ease the access into those types of facilities for both parties. But yeah, I totally agree that more compensation is a good starting point already to make it a bit more attractive, at least for new prescribers that are opting to take on this type of opioid agonist treatment prescription. Definitely.
Yeah. I mean, I think a wonderful way to sell it to GPs, you shouldn't have to sell it, right? But like, if you look at the effect size and the number needed to treat, like for OAT versus so many other medications, like the effect size is huge, right? In terms of reducing morbidity and mortality. It's a sort of thing where you say, okay, you've got a chronic disease and there is this medication which improves outcomes so much. Will you prescribe it? It's like, well, yeah, absolutely. Like, I want to help my patients. I want to reduce their likelihood of dying and getting sick. But then when you say, oh yeah, but it's related to these things, people become very, very cautious. And again, I understand why. It's like a complex area. It can be a complex area of medicine to get into, but I think that the benefits of these medications cannot be overemphasized. That they're tremendously powerful. I know, Tom, you as well have done work on this, like things like all-cause mortality and sort of, I don't know, rates of cancer and other things, if I remember correctly, are reduced amongst people with opioid dependence who go on OT versus people who don't. Like, the engagement in care is very important. But it's not enough just to bang the drum, right? And just to say, you should do this because it's effective. We need to support practitioners who want to work in this space, because it can be very, very hard, and it can mean you don't get paid very much. And that kind of sucks if you're working your guts out.
Yeah, for sure. I think Kevin also makes a good point when we responded to one of the questions about this, just saying combating the perceived stigma that surrounds people who use opioids, of course. It's a major thing as well. And then also, and then I would say the medications themselves too, as you said, Rob, just some of the stigma that just comes with OAT in general can be a barrier, I think, to use even some GPs as well. And as you said, providing that information and evidence may be supportive in that. I'm wondering if I could, there was a question about how clients were selected and how we mitigated selection bias. And Mauda, I know that your survey was a little bit different than the overall opioid dependence survey. So the overall opioid dependence survey, we tried to recruit people from rural areas, from throughout New South Wales that were from people that were on and off treatment. But I don't know if you wanted to mention anything in relation to your qualitative survey as well.
Yeah, sure. We used professional networks within the peer worker community, in which we communicated a message basically asking for people that were in a supportive role within harm reduction services that had knowledge about engaging with opioid agonist treatment, which was disseminated throughout the whole state. And then based on that, we got the first participants. And then further from that, we also snowballed within their personal networks, whether they knew of somebody after finishing the interview, like, okay, now you know what we discussed. Do you know of anybody that could really tell a good story about all of these topics? And yeah, we got luckily 13 very nice people to speak with. So yeah.
A very quick question for me as well, and we may have to end on this one, but was anything related to correctional services brought up in terms of medication choice? And I may have missed something during the presentation, but I'm just curious in terms of a lot of people not being able to be initiated on methadone, potentially in prisons, or well, or just the potential lack of choice, I don't know, during or after prison, and just if that came up at all, or if people perceive that as a issue in continuing services.
Yeah. I actually had one instance, which I recall now, at least, that was specifically discussing this, but that was related from a peer worker that was describing how people in prison get put on Buvidal, from their perspective, of course, their experience. And they were explaining how this can be potentially also guided by misinformation. People just think like, oh, it's some type of medication, I will get some sedative effect from it. But of course, Buvidal works differently. And then when they are entering out of the prison, they are immediately being directed to the harm reduction facility that they, for example, were working at, and how this population then takes on a relatively big part of the clientele group that they can take on. But as soon as they enter out of treatment or out of prison, I mean, apologies, they are actually not interested at all in continuing to pursue opioid agonist treatment. So it's then a bit of a confusing scenario where they do have a spot on a harm reduction facility for opioid agonist treatment, but then they will never show up, and it will become this big hassle of, yeah, how do we actually reach out to these people, and what type of miscommunication occurred that we're now in this situation.
Well,
So
yeah, I think that's an overall, a overall continuing thing that we need to address is how we connect people with care after they leave prison. I don't know if you had any thoughts there, Rob, but there's also, I think, just in terms of the gap of when people would need their next dose after they leave prison. It's a different, I guess, type of treatment, and strategies to how we connect people with care after prison is really important, and how we help integrate people back into services when they come back into the community. But Rob, I don't know if you have any thoughts.
Look, not that I could put together in 1 minute, probably.
Yeah,
From
no,
the
sorry.
team, and I mean, I think just in general, like, it must be a challenging space to work in, justice or OAT.
Absolutely.
The limited access to, like, it's hard to get methadone in prisons now. Most people are on Buvidal. Coming out of prison, yeah, I feel like the systems do their best to ensure facilitation of ongoing treatment, but it can be challenging for a number of reasons. But yeah, how long have you got? But that should be a whole nother webinar, I reckon.
For sure. For sure. And thank you both again for joining, and thank you everyone for joining. And really appreciate your recording of the presentation, Matt and Rob, for all your time for joining us today, and everyone again for coming. And please make sure to look up the next webinar and join us for that as well. So thank you, everyone.
Thanks, Tom. Now.
thank you.
Okay.